For us, I think Semrad offers the promise that regardless of how complicated and unavailable our patients' communications seem to be, that they can be translated into commonly shared affective experiences, into more universal human terms. Well, I remember the first time that I had the pleasure to read anything written by Dr. Semrad. I had been at Boston State a little bit of time, and I had begun my individual supervision with Dick Kahn, and I was treating a very unavailable, psychotic, regressed, autistic young man who, when he would talk at all, would talk only about professional wrestling, which over 7 years I learned a great deal about. But I remember, and I read it, when I read some papers and his book edited with Dr. Van Buskirk, I was absolutely astounded. I have never had a response to anything I've ever read since or before, and I read lots of books on schizophrenia, lots of books on psychosis as an attempt to sort of somehow bind my anxiety of this Boston State experience. We tended to get the people who psycho rejected, and we tended to get the people who most everyone rejected. This was in the late 60s, early 70s at that time. But when I read this work by Dr. Semrad, for the first time I felt in some way that reading this material made what my patients were saying much clearer. And coincidentally, listening to my patients made what I was reading much clearer. And I've never really had this experience before and since, and it was most powerful. I want to close with just a little comment from a patient. One of the things that, although not knowing Dr. Semrad, I was supposed to take his seminar at the Institute just before he died, and felt awfully bad that was not something that I could begin with him and get to know him. But through his reading, I tried to sort of pass on to the residents, and in the clinical programs that I have the pleasure to develop and oversee, some of what he stood for, including the important notion that treatment of people who hurt takes a great deal of time. But in the context of this, I see patients on the ward, and occasionally some of my residents permit me to take a patient into therapy and follow them over some time. And I just began to see a young woman in her late 20s who has been on one of our wards most recently for several months, and with a very long psychiatric history, at least going back to her late teens, early. She can do a lot of other unpleasant things, but she can write. And her writing, her poetry is very interesting, and she's begun to share that with me. And I wanted to share with you just a little piece of her prose, because I think in some way she and Dr. Semrad knew each other at some level. This is in a journal that she's making up about a patient, a fictitious patient, and it involves a note to her doctor. This was written several years before, at a time when she was in great turmoil and was cutting herself a great deal and trying to set herself ablaze. Anyway, she wrote, Doctor, do you really want to know what it's like to be me? First, tear up your notes. They're only your interpretations. Destroy my medical chart. It's not me. Listen to me, especially the times you hear no words. Thank you.
I want to first say that I neglected to tell you that Dr. Siegel has been for the last 2 years Director of Clinical Programs at the Cambridge Hospital, one of the co-hosts and sponsors of this two-day symposium. We'll now have, for how many minutes, Susan? 10? Coffee break for the usual mythical 10 minutes. All right. Use that. I think we begin. The next paper will be presented by Leston Havens, who's professor of psychiatry at Harvard Medical School, currently at the Cambridge Hospital, formerly and for many years at the Massachusetts Mental Health Center. He is a faculty member and training analyst at the Boston Psychoanalytic Institute and has published many papers, several books of great importance in surveying the entire breadth of our field and various approaches to the disturbed person. It's a particular pleasure for me to introduce Leston when I have the occasion to do it, since in addition to being a pleasure to be on panels with distinguished people, it's a pleasure to introduce someone that one has grown up with. I knew him when he was only distinctive and not distinguished. And but he has, not that it was a great surprise that he rose to the eminence he enjoys. His paper will be on conditions for engagement.
Is that yours, Harold? What I'm going to try to do, is that noise? Okay, good. What I'm going to try to do is to show the sources or investigate the sources of the way in which Elvin Semrad worked, with the particular purpose of showing how he diverged from some of the principles that Dr. Searles has so brilliantly and in such detail expounded to us this morning. So that these remarks are specifically cast, if you like, in the form of a rebuttal to Dr. Searles's engaging, wonderful, illuminating, brilliant review of the tape that we are all now familiar with. There have grown up, as we know, many different approaches to the patient and also to the psychotic patient, but I think this opportunity to contrast the way Semrad worked with the way Dr. Searles works, which was one of the purposes of this conference, is a particularly illuminating one, presenting as it does to all of us specific decision points in our own everyday work, whether with psychotic people or with other patients, particularly characterological problems as well. Now, I think it will be helpful if I begin with a remark that one of Dr. Semrad's principal teachers liked to make, a man known to many of you, Ives Hendrick. He was the man whom Elvin said was his most useful teacher in the Institute. Hendrick liked to say that when he first came into psychiatry in the late 1920s and early 1930s, the great problem was to stop the doctors talking. And some of you who knew him can imagine how he said that. And then he said, when he encountered our generation, my generation, and I first encountered this saying in 1954, he said that by 1954, this task of silencing the psychiatrists had been accomplished with such completeness that now it was necessary to get them talking again. Now I highlight this because Having said that, and made a typically acute historical remark, for a reason I'll expand on in a moment, he then did not tell us how to talk. And one of the reasons that Semrad was very important in my own development, and also the reason that Harry Stack Sullivan was very important in my development, was they both introduced ways of working which answered, in part, the question that Hendrik had put to us. Now, what's the historical remark of this aperçu of Ives Hendrik? In essence, it is this. For the first half, approximately, of the century, our work was dominated by objective descriptive psychiatry, as it is once again now, in which the tool to be used was the method of orders and questions by which the patient was essentially interrogated as to their personal experience, history, and the rest. And this material was taken as being reliable, as it once again is in this era of DSM-3. The model of this, the model of the mind implicit in this, is of a container which has an open roof in which one can, by these interrogations, reach in and draw out reliable information. Now, that was the first half of the century. Now, we know what happened in the second half. That is, Freud taught us that what you got by questions, what you got by reaching into the head, was essentially what he calls secondary process. It was essentially compromise formations which did as much to conceal as to reveal the reality of the patient's experience. And for that reason, he elaborated a technique by which the therapist's interventions were restricted much more sharply, indeed developed the method of silence. And out of that, and of course, above all, the method of transference development, it was hoped that the deeper reaches of mind, inaccessible to conscious questioning, would reveal reliable, formidable aspects of the forces at work within the patient. Well, here we were, and here you are. Now the 80s, then the 50s. But what were we to say? What was the language that would reach through these layers of the mind to the real matter at hand? And most of all, if we were to be talking with psychotic people whose egos, we were told, were either disintegrated or narcissistically regressed to projection, distortion, and denial, how then were we to talk to these people? What kind of an understanding could we achieve, not only through the inherent difficulties of the mind, but with a mind now lost, disintegrated, or regressed? Can I have some water? Nothing I'm going to say will be of any interest whatsoever unless that point is compelling. Perhaps some of the force of it begins to come through to us when if we had the experience that 2 or 3 people reported to me having yesterday when they heard this tape of Elvin. They said, he talked a lot. He talked a lot. Well, what was he talking about? And what gave him the warrant to think that he could defy the great Viennese injunction about the difference between secondary process and the instinctual forces at work? Well, that's the subject of my remarks. And I hope Dr. Searles will take in good spirit, because God knows I have good spirit toward Dr. Searles. God knows it, but he may not. That in the discussion that Dr. Searles gave us, he talked even more. He suggested a great many interventions, fascinating reflections, particularly on the transference and countertransference aspects of the case. Furthermore, another feature, I think it's fair to say, of his suggestions about the interview, how he would have done it differently, as he said, was that he would have directed himself much more to the hostile, destructive parts of the patient's mental life. Now, some of you can already hear, perhaps in the background of these contesting ideas, a debate that's going on in a larger forum than our own. That is the debate between Kernberg and Kohut about the forms of intervention, particularly in borderline and narcissistic cases. And that will come back to us, I think, as a theme as I go on in these remarks. Now, what are we to answer? Both to Hendrik's question about how can we talk, and second of all, about the suggestions that Dr. Searles makes as to how this interview should properly be conducted. Because, of course, as he so ably demonstrated, that is not the way that Dr. Semrad conducted that interview. Now, the central point I'm going to suggest to you is this. It was Semrad's contention that until personhood, or what others would call selfhood, or what others would call a sense of real existence, had been touched and found in the patient by the personhood and selfhood, etc., of the therapist, until someone had been found and reached in the patient by the therapist, any remarks made to that patient fell essentially into the darkness. That the first business of the work was the engagement with someone who might be able to use the materials that would be forthcoming from the therapist's mind. And in part because he had so long worked with fragmented and deeply regressed people, as Dr. Searles has, of course, Dr. Semrad was skeptical, profoundly skeptical, of the extent to which it was possible to easily engage someone in the work. And so, the apparent blandness of much of his interventions that Dr. Searles has so clearly pointed out to us, the apparent blandness of that is the covering for an effort to reach someone, to bring someone safely into this contact with him. He was seldom critical of other approaches to the work, but in my context with him, with Dr. Semrad, it was apparent to him, it was his opinion rather, that more active interventions, particularly with people recovering from or going into psychoses, were very likely to precipitate unpredictable results. And he used to talk about how I was supposed to go on the wards, or he was supposed to go on the wards and do what he called picking up the pieces. Now my second point, how did Semrad propose to go about engaging the fragmented or regressed someone, to developing, if you like, or making the beginnings of the development of a contact with a possible person or self in the room? Now, I suggest to you there were two ways by which he went about this, and they were well illustrated in the tape that you saw yesterday. The first of these ways was that he did not attempt to engage with the patient. He did not, in other words, assume that there was a patient yet in the room. He knew that although the patient's body might be in the room, their mind might not only be lost as in psychosis, but might be most unavailable to any kind of thing like communication or contact. Their minds not only might be sent away voluntarily and imaginatively, but they might be so scattered and preoccupied as to make any enduring, comfortable contact, workable contact, non-destructive contact, impossible. So what did he make contact with? Well, you saw it here in this interview. He made contact with the patient's suffering, not with the person, but he hoped by reaching the patient's suffering, points of distress, to share that distress and therefore give the feeling of being understood to the patient, and then by taking off some of the pain of that distress, freeing the patient up to come a little more into the room. So now, The purpose of his confrontations, which have been spoken about here many times in many ways, the purpose of his confrontations, I submit, was not to provide insight, because the concept of insight supposes that there's an ego in there capable of hearing, using, thinking about what is being pointed out. The purpose of the confrontations was not insight. The purpose of the confrontations was to bring the distress in so it could be shared. Now you see, in part, what Dr. Siegel was talking about when he emphasized the affects. Now I think this idea is familiar to us from another writer who happily Dr. Searles mentioned in his marvelous ending of his speech, his absolutely unique and distinctive and wonderful ending, Winnicott. So let me say what I just said in Winnicott's language, and that may make it more familiar. Winnicott warned the therapist against engaging the patient on the basis of false self in an endless set of interpretations and ruminations about defense mechanisms. That's a paraphrase. Better, Winnicott said, better, he said, to acknowledge the patient's non-existence, absence, emptiness, disintegration, than to proceed on the basis of a false self put forward out of compliance, which could only reinforce the negative, destructive, and unreal parts of the patient. That's what Semrad meant in this first point that I'm making. And of all of the much revered figures in the last 30, 40 years, the one showing what's closest to Dr. Semrad in his thinking, in his clinical experience, in his emphases is surely Winnicott. Now, the second way by which he proposed to try to find someone in the patient with whom he could deal, he liked to deal, that someone with whom he could deal was by an exquisite sense of what the traffic would bear. Now, in this interview that you saw, not only does he search through a very long series of historical sources of distress, in a way, I think, that he would not have done except as a didactic demonstration. It's a kind of mental status examination performed dynamically in an existential context for the purposes of teaching. I don't think he would have done that in an ordinary clinical setting, except perhaps he would have protested using his old definition of the chronic patient. Some of you recall, no doubt, maybe it's in Susan Draco's book. A chronic patient is an acute patient whose pain was not initially touched. Maybe that would have driven him to a quicker review in some people, but on the whole, he would have been afraid to have the traffic bear that much in a single interview. So he was exquisitely sensitive to what we can call respect for the nascent, barely existent, very tenuous person who might be in there to be contacted in what would be a comfortable way. See, his constant fear was of the transference, countertransference problems, but he feared that if he entered them too directly, he would repeat inadvertently some kind of horror in the patient's relationship with other people by too active an investigation. Now here again, we can turn to Winnicott for a different language. You remember in one of the many wonderful passages in Winnicott, and particularly in the article with this, which has this name, he discusses the child's capacity to be alone with the mother. That is, the child, he says, the healthy child, hopefully will learn that it can be alone with the mother. Now, the paradox in the statement is, of course, what first invites us to it. How could you be alone with someone? Well, then you quickly get the notion, don't you? When you're alone with someone, it means that other person will let you alone. That you can go about your own business supported by their presence, but not invaded, not intruded on. not reflected on even, by this surround, this holding environment, if you like. Winnicott thought, and I know that Semrad thought, that most patients could not be alone with anyone, and that indeed their patienthood might have been importantly shaped by their failure to develop this capacity to be alone with someone. That is, to sit with someone with no sense that you had to perform or worry or attack or seduce, and ditto that the person you sat with had a similar freedom from all the mental invasions which go to make up so-called social life. Now, one of the things that everyone has been struck by, I think here, even more than the amount he talks, is the way that he was silent. And his silence had a quality which I did not see in my other teachers. Most of my teachers' silence, as most of mine I'm sure too, most of my teachers' silence was the silence of insistence. The silence of the fundamental rule of analysis. Say whatever comes to mind. And the silence had about it almost a boot print of demand. Now, the thing about Elvin's silence is that they did not have that quality. He did not seem to mind that neither he nor you would do anything. That the time might pass, even in the busy world of Harvard, without it making very much difference. Now, that silence was a transference interpretation, if you like. It was a statement that Dr. Seelig has given us in the intermission. Dr. Seelig suggested the topic for my talk, and I thought it was a brilliant suggestion. He said that what Semrad was able to do was to deal with transference non-verbally, or silently often. And that's the point I'm on right now. So that by allowing someone to be alone with you, without too much busyness, invasion, interpretation, or understanding going on, you are beginning to suggest to a person that this thing that they might become, this self, this human being, didn't have to worry so much about your brilliance, your understanding, or even your presence. So that, I'm saying, Semrad was operationalizing, if you like, the principle of respect or the principle of Winnicott of allowing someone to be alone with you. Now, those remarks are general. They don't address yet technical problems, and I want to take the rest of my time to say something about the technical problem of these matters. First, two more general remarks as an introduction to more technical things. He did two things that were implicit in his silence, and we can add them to his silence and his sharing distress, if you like, to make 4 points about the background of his technique. First, that he would reach the person through their distress. Then he would allow them the freedom to be, if you like. And thirdly now, he was a great, what you might call, naturalizer. As we all know, most of our work falls in the pathological sphere. Psychiatry is absolutely unique in medicine, and perhaps in psychology too, for having almost no conception of the normal. One of the reasons that psychiatric work is so devastating to people when they first come upon it is that there is no ordinary background account given of the normal part of a human being. We don't take a pulse or respirations. And in our mental status examination, the only parts that describe normality are neurological, things like calculation and the like. The psychologists try to tell us something from their testing about the normal, but we psychiatrists and psychoanalysts, for the most part, ignore them. So all psychopathological findings float. They float. And that's why when someone says that you're a little dissociated or a little paranoid, you wonder. Because unlike general medicine, where people do not speak adjectively, you do not speak of being cancerous or tuberculous. You do speak of being diabetic. But on the whole, in medicine, it is always cancer of the particular local thing, with the implication being that, thank God, the rest of you is more or less free of it. But that is not the way we think, and that is not the way patients experience us. We think adjectively. You are neurotic, you are manic, you are schizophrenic, you are borderline, you are filled with this thing. And when the students say somebody's schizophrenic to me, I look at them as hard as I can, and I say, how schizophrenic? Now, this is the point I'm trying to make, that Semrad had a natural affinity for what might be healthy in people, partly because he was a comparatively healthy man himself. He was a comparatively healthy man himself. And he liked to find things in people that he could engage with on a healthy basis, as well as a basis of distress. And so, when you were with him, you not always, but often had the experience that he naturalized, validated a great deal of things that you thought were surely signs of your imminent psychosis. So that you had this experience of being, in a sense, more comfortable with the psychopathological phenomena that you had encountered. Now that meant that a certain amount of pathology might be overlooked or underestimated, as Dr. Searles has warned us about, at least in the early stages of it. But of course that wouldn't be a bad side to err on if you were trying to engage someone and not frighten them. Nor did it mean that later on your investigation might continue into those other matters. Furthermore, as Al Margulies has taught us, the purpose of the first interview is to have a second interview. and that is a systematic principle, because we cannot find out enough in one interview to justify any of the things that we ordinarily do. So it takes a very great deal of time and study and investigation, just as in general medicine and psychology, in order to know with some sense of reliability what you should be about. And so when a naturalization process is set about in the interview, you are essentially helping the person to get to not only the distress, hopefully, that you can share and lessen, but also a sense that the person is in safe hands. Now, the fourth principle that is active in this interview and in other work was that he allowed himself to be touched by the patient. There's an old saying in general psychiatry and medicine that nothing happens until the doctor is touched by the patient, until the doctor is moved by the patient, you might say. And it is by moving the patient, the therapist, that in turn the therapist is sometimes able to move the patient. He allowed himself to be moved. And you remember in Terry Maltzberger's remarks yesterday, he spoke about coming to Dr. Semrad and weeping about his frustrations, his inadequacy, his disappointed hopes, and Semrad saying to him, if you will just cry like that in front of your patient, perhaps she will stop cutting her wrists. In other words, if you will be able to allow your being moved to be to some extent shared in the experience, you have a better chance of touching, engaging, and holding this difficult and elusive woman, he said. He was not neutral. He was not neutral. He burned inside with a sense of injustice, powerlessness, activity, eagerness, and his movement, however, was all affective and not political or motor or whatever, but he burned. Now just some remarks about technical matters. In my opinion, the word that has done most damage in the sense of confusing our deliberations about technique is the word interpretation. Interpretation is a word used by everybody to describe everything. Elvin used it just the same way. And he would do things that in nobody's definition of interpretation he would call interpretation. For example, when you ask yourself what you're supposed to do in order to acknowledge, bear, and put in perspective, when you ask yourself that question, let me give you examples of what he thought you should do. And he called them interpretations. And then when I said to him, that's a funny kind of interpretation, he said, well, I know, but they'd like it downtown. Acknowledgement is an appropriate, this is Elvin quotation now, acknowledgement is an appropriate response of the therapist to the patient's feelings or expressions. And what he meant by an appropriate response, you can acknowledge an acknowledging response. And it was usually a grunt or a noise of assent or an expression of beaming understanding. That was the form of his acknowledgement. And he called those interpretations. Incidentally, Kohut does the same thing. If you look carefully at what he calls interpretations in either the analysis of the self or the restoration of the self, they're usually simply repetitions of what the patient has just said. Very Carl Rogers-ish account of interventions. Any case, so that to acknowledge means to respond appropriately to the patient's assertion with a feeling. And it was generally a feeling of acknowledgement, an empathic exclamation or expression. Bearing, he said, also involved interpretation. But in fact, technically, what bearing meant was that you looked inside yourself to see if you were having the same feeling. That's how you know whether you're bearing. It's not by what you say. You may express the same feeling if you like, but basically you are in determining whether you are acknowledging or now bearing. You look into yourself and see if you are having the feeling that you think is appropriate for the patient. And now what is putting in perspective? For a long time I thought that must mean interpretation. And indeed he called it a primitive form of interpretation. And what he meant was that when you put something in perspective with a patient, it goes something like this. The patient is berating themselves because they are a whore or because they have some sinful propensity. And